we have Dr. Veronica Bruno. Dr. Bruno is a neurologist and movement disorder specialist in Calgary. She received her medical degree and neurology residency in Buenos Aires, Argentina, and completed her fellowship in movement disorders at the University of Toronto and a Master's of Public Health degree at Harvard University. Dr. Bruno's primary interest is treating advanced Parkinson's disease with a particular research interest in pain and other non-motor symptoms. So I will welcome Dr. Bruno here, and she'll be presenting to us today on the topic of autonomic dysfunction in Parkinson's. Welcome.
Thank you very much. I hope you can hear me well. Thank you, Bri, for this introduction, and thank you all for staying there. It's really nice to see you all on the other side. I recognize a lot of familiar faces and names, and I think you're doing the most important thing that you can do, that is getting to learn a lot about Parkinson's or wherever your diagnosis is. And I guess sometimes it's a bit scary and challenging to hear potential symptoms or potential things that may happen. But always remember that information is power, and you're doing the right things. The more information you get, the more able you are to advocate for your own health, go to your doctor and ask specific appropriate questions, and also help us understand more about the disease itself. So thank you for the invitation, Parkinson's Association of Alberta, and again, congratulations, this is great. As Bri mentioned, I am one of the neurologists here in Calgary who works at the Movement Disorders Program. I'm also a clinical researcher, and what you can see in the picture is my research team. And basically, as mentioned, what I'm trying to do is to work on those symptoms that affect people as the disease advances, as Parkinson's disease advances. And in the context of that, we recently started a new program called the Advanced Care Team for Parkinson's that is hopefully going to be very helpful for all of you. The topic that I was requested to talk to you about, and I really want this to be a conversation where you can ask as many questions as possible, is a very important one, that is autonomic dysfunction in Parkinson's. So just to start, I want to say that I have no conflicts of interest related to this talk. I work in some advisor boards, and I have some research funded by some pharmaceutical companies, but there's no really conflict that you should be aware of. And the agenda for today is first try to understand what is autonomic dysfunction, why there is autonomic dysfunction in Parkinson's, and this also works for some of the atypical Parkinsonian syndromes or Parkinson's plus syndromes. And then we will go through some of what we call autonomic symptoms. I will try to do it very pragmatic and practical. So I will chat a bit about what happens and why, but mostly try to give you some tips about how to manage those symptoms, or again, particular questions that you can go ask your doctors or your health team about. And then we will have some conclusions. In terms of the symptoms that we will review today, I will focus on excessive saliva, delayed gastric emptying, constipation, bladder issues, sexualized changes a little bit because we had a great talk about it, orthostatic hypotension or low blood pressure, and temperature regulation. So as the first thing, and you heard my interest is non-motor aspects of the disease. For most of you, this at this point is known and is general knowledge. But for many people, this is still not so clear. So Parkinson's disease is much more than tremor, stiffness, and slowness. Parkinson's disease includes a lot of what we call non-motor symptoms that affect cognition, mood, autonomic dysfunction, as we are going to discuss, sleep disturbances. So this, unfortunately, even if we have known Parkinson's for more than 200 years, was not known. For many years, we neglected the non-motor aspects of the disease. And that's why they created such a big burden, and we have so many limited treatments. As you can see, the graphic that I'm showing are the articles about non-motor symptoms of Parkinson's that were published. And up to 2006, there was not much done about it. And in the last 20 years, we started to produce much more information. So in that context, in the context of the non-motor aspects of the disease, is where autonomic dysfunction appears as a very relevant actor. So what is autonomic dysfunction? So autonomic dysfunction happens when the autonomous nervous system fails. And the autonomous nervous system, that is a very difficult name, is the one that controls the physiological functions of our body that we cannot voluntarily control. The other name for autonomic dysfunction is dysautonomia. So what is this autonomous nervous system that is failing and is not working well in Parkinson's? So when we speak about nervous system, we always think about the brain and the spine, and that's what we call a central nervous system. We also have neurons and control of the nervous system outside of the brain and the spine, and we call that peripheral nervous system. And an important part of that is the autonomous nervous system. The autonomous comes from autonomy. It's a nervous system that works without any voluntary control. So it goes and manages our glands and internal organs, things that we cannot voluntarily say, I'm going to move my bowel now, or I'm going to move my thyroid now. So is the component of the nervous system that regulates those involuntary physiological processes. They include a lot of them, like our heart rate, our blood pressure, our respiratory movements, our digestion, and our sexual arousal. And why is there autonomic dysfunction in Parkinson's? And this, as I mentioned, is not just for Parkinson's. It could be Parkinson's, it could be Lewy body dementia, it could be multiple system atrophy, even if there are some differences in those. So that protein that it was mentioned today that we think has a very relevant role in Parkinson's, that has a very difficult name, it's called alpha-synuclein, doesn't only accumulate in the brain, it also affects those neurons that regulate the autonomic function. That's why in parallel, and sometimes many years before developing a tremor or stiffness, the body of a patient or a person living with Parkinson's starts to have some of these autonomic symptoms. And this is interesting because now we know that this autonomic dysfunction many times happens many years before any other symptom. It's classic that when you are come to the neurologist for the first time, we ask, for instance, about constipation, and you said, yeah, but I have been constipated for the last 20 years, so it's not related. But in fact, we know that, yes, probably that was the first symptom of the disease, and it takes many years for the rest of the symptoms to appear. So is it common? It's extremely common. And I'm pretty sure that each one of you will identify yourself with at least one of the symptoms that I'm going to mention today. It's one of the most prevalent non-motor aspects of the disease. And it can happen, as I mentioned, from very early, before you even develop a tremor, to very late in the course of the disease. So what are those symptoms that I'm going to chat with you about? As I mentioned, everything that is related with internal organs or glands. So salivary glands, all the cardiovascular function, including our blood vessels, our stomach, our bowels, our bladder, our genitals, and also the innervation of the skin. That's why temperature regulation is also affected. So I will start with excessive saliva. Excessive saliva, in fact, is not a classic autonomic dysfunction symptom, and it doesn't happen to everyone. It usually happens very late in the course of the disease, and a little bit of it is related with the lack of control in the production of saliva, but a lot of it, and the main part, is in fact that the movements of the face are a bit slow, so we don't have that automatic response that we have without thinking of swallowing the saliva that is produced, so it tends to accumulate in the mouth. And if it's a lot, we can have some drooling. So there are some tips that we can use to reduce the amount of saliva that we have in our mouth. Usually, if it's only at night and you just wake up and the pillow has some saliva, we don't do much. But if it's something that is making you uncomfortable during the day because you want to go see your friends, but you don't want to have like a saliva coming out of your mouth, or you feel you are having to clean your mouth all the time or have Kleenex with you all the time, or if you hurt some people find that the saliva can hurt the corners of the mouth, there are things that can be useful. Like the easiest thing is, if you don't have issues with swallowing, would be to chew some gum or some hard candy, preferable like sugar-free, because that act of swallowing or chewing kind of produces that unconscious reflex of swallowing. So the saliva goes down as a reflex. Another alternative that you can discuss with us, with your healthcare team, is using some drops that, in fact, the most common ones that we use are eye drops with atropine. And you can put some under your tongue, and that will reduce the amount of saliva in the mouth. It's a bit tricky because some people find that the mouth gets too dry with the drops and that they can have little like lesions, like ulcers. If you have some memory issues or some hallucinations, those drops are not ideal. But it's something that it can be tried, and you can see if it's helpful for you or not. And the last treatment that is in fact very safe and very easy to do, but needs to be done by someone with experience, we do it here and they do it in Edmonton, is injecting botulinum toxin, like, like Botox or Xeomin, those brands of botulinum toxin, in this gland that you can see here, that is the parotid gland, or in these glands that you see under your jaw, that are the ones that produce most of the saliva. It's a very small needle. It takes approximately 2 minutes. And what the botulinum toxin does is reduce the contractions in those like channels that bring the saliva out, so you don't have so much saliva going to your mouth. It's pretty straightforward. So if you are dealing with this problem, there are a few solutions that you could try. The second symptom that is very important is delay in the gastric emptying. So we know that slowness, as it happens with some of the movements, happens with the movements of the bowel. What we call delay in gastric emptying is basically that the stomach takes too long to empty its contents. You may feel that after a meal, you feel bloated because it takes much longer to perform the full digestion process. And the cause, as I mentioned, is because the neurons that are in the walls of the stomach are also affected by Parkinson's disease. If it's severe, it can lead to nausea and vomiting. I want you to take a look at this picture. It's not very nice, but it's a picture of a patient that had an endoscopy, and this is the stomach. I don't know if you remember this, but the levodopa, the yellow pills, are absorbed in the little bowel, in the small bowels. So it needs to pass your stomach to reach the bowels. So if your stomach is emptying very slow, this can happen. So this patient took the pills 1.5 hours before. So you take your pills, you think, okay, I'm going to have an effect in 20 minutes. But if your stomach is very slow, those pills may not kick in for hours. And moreover, they may kick in all together with the next dose when you have a bowel movement and all the bowels move. So this is something very important to consider, because it may change. Sometimes you said, okay, these pills are not working for me anymore. Maybe that was not the case. Maybe they are just not kicking in time because they're staying in your stomach instead of reaching your bowels every time you eat, you take them. What happens if this symptom gives you nausea and vomiting? This is very common in the beginning. It's not so common as your body kind of gets used to the disease and to the medication. So it can happen, nausea and vomiting can happen as a primary feature of the disease, but it's also a very common side effect of some of the medications for Parkinson's, as you heard in the first talk this morning. If this is due to a new medication, so if you were just diagnosed and just started with levodopa, usually the body, as I mentioned, gets used to it, and it's an effect that tends to disappear. But for some people, that's not the case, and the nausea and the vomiting can persist. If it's mild and it's like, yeah, I don't feel great, but I can tolerate it, usually we don't do much, but it can get very severe. So one potential tip for this is, we are very, very diligent about taking the pill separate from protein because we don't want to interfere with the absorption. Well, sometimes, particularly at the beginning, it may be better to take the pills after a meal or with the meal to reduce this nausea sensation. You will say, okay, Dr. Bruno, decide what should I do? Well, it depends on you. Not every single person has that interaction between proteins and levodopa. And not every single person has nausea. So if your main problem is related with nausea or vomiting, it's better to take the pills with meals. If you feel that if you take the pills close to the meals, they don't seem to kick in well, then separate them from the meals. If your nausea is very severe, you need to call us, because that can lead you to stop eating as much as you need to eat, to lose weight, and we know that that's not good because you need to have all your strengths. If, as I mentioned, this happens only when you take the levodopa, if you talk to us, to your healthcare team, we may consider adding a medication that likely many of you already know, that is called domperidone. Domperidone is a medication that blocks the dopamine effect outside of your brain. So it's the only medication that we can, or one of the only medications that we can safely use to reduce the nausea without affecting the way the pills work for our Parkinson's. So it's something that you can consider, and you can try to see if it reduces that feeling. There's another possibility. You know that the pills that you take have levodopa and carbidopa, or levodopa and benseroside. That second drug in your pill, the benseroside or the carbidopa, are there to reduce the side effects of the levodopa. So sometimes we can prescribe additional carbidopa, like some pharmacists may do separately, if there is a big issue with the tolerance to the medication. You can also chat with your family doctor, because remember that not everything is Parkinson's, and sometimes you may have some reflux, and all the pills that you have to take can make that worse. So some anti-reflux medications like pantoprazole may be helpful. This is a very important thing for you to remember. If you go to the hospital with nausea for any other reason, you can have a gallbladder problem, you can have a peritonitis, make sure they know you have Parkinson's, because there is a very common medication that we use for nausea, Maxeran, you probably heard of that, that is contraindicated in Parkinson's. It can make your Parkinson's much worse. It can increase your tremor, your stiffness, and slowness. So if you go to the hospital, you always need to tell whoever is there, I have Parkinson's. I know that there are some medications that I cannot take. So that person, you would assume that happens automatically, but that doesn't happen sometimes, remembers that you shouldn't take the medications that would block the dopamine effects in your brain. And if you're planning to try something over the counter, it's good for you, it's a good practice to just give us a quick call and says, is this safe to take for me? So we make sure you are not making anything worse. Another extremely important symptom is constipation. And the numbers say that approximately 3 every 4 people with Parkinson's will have constipation. In my personal experience, it will be 4 every 4 people. I think constipation in some stage during the course of the disease will affect every single person living with Parkinson's. So how do we define constipation, and what does constipation mean? This is very important, because some people say, well, no, I have bowel movements every day, so I'm not constipated. But then when we ask in detail, that passing those stools is extremely difficult. And I spend 1 hour making an effort in the toilet to pass those stools every day. So in general, if you have less than 3 bowel movements a week, that's constipation. But particularly if every time you have a bowel movement, it is very difficult to pass, that is also constipation, and it is something that we need to treat. I cannot put enough emphasis on this. Constipation is as important to treat as taking your levodopa, and I will tell you a bit more about this. So it's part of Parkinson's, and as I mentioned, sometimes it's the first symptom many years before you develop the rest of the symptoms. It happens for the same reason that the gastric emptying delay, because the nerve cells around your bowels are affected by the Parkinson's pathology. Sometimes people think it's the medication. Say, no, I will not take another medication for Parkinson's, because every time I take, let's say, X medication, my constipation gets worse. That is likely, but it's not the most likely explanation. The most likely explanation is still just the Parkinson's. It can lead to very important complications, and is one of the most common causes of people with Parkinson's ended up in an emergency department. Because if you are very constipated, you can have an obstruction, and you may need to have mechanical removal of a fecal impaction. Or if it stays there for too long, can lead to a perforation of your bowels, and that's clearly an emergency. But there's much more than that. First, it's extremely uncomfortable. It makes you feel bloated. It makes you feel heavy. It makes you sleep badly. It makes you move slowly. But also, what I mentioned before, if your bowels are very slow, that will also influence your gastric emptying, and your pills may not kick in time. So a lot of what's going on with your bowels will affect the way your medications work. So you would be surprised about the amount of times that someone comes and says, I'm having a wearing off 2 hours before my next dose, so my symptoms come back. And then, oh, how many bowel movements are you having? And the person says, well, I'm having a bowel movement every 4 days. And then we treat the constipation, and then the wearing off disappears because the pills are much better absorbed. So remember, constipation is a very important part of the disease. It's so important that in terms of research, we are now considering that Parkinson's may start in the gut and then migrate to the brain. And now we know that the bacteria that people with Parkinson's have in their bellies are completely different than the bacteria that people without Parkinson's have. So we're learning more and more about how important the bowels are for Parkinson's and how important it is to treat the symptoms in order to get a good symptom control. So what can you do? This is easy to say, hard to do. I tell you this and I always feel guilty because I forget to drink water most of the day. But drinking water is important because you will not create any feces if you are not well hydrated and you don't drink enough water. So you make sure you have an alarm for your meds and an alarm for your water. All these watches that are pretty cheap now on Amazon can have water reminders. And then you set your water reminder and you drink water because it's very important for the bowels to be hydrated. I mark the word foods in there because fiber is important, but it works much better if it comes from food. So prunes, apricots, lentils, so things like raw vegetables, like raw fruits. Try to make the fiber come from the diet. The more natural the fiber is, the better it works. So eat the fruit with, like the apples with them. I don't remember how to say the outside, but basically take your fibers from your diet, mostly. Use pre and probiotics. This is related with the fact that I mentioned before about how we know more about what happens in the bowels now of people with Parkinson's. And there is evidence that, as I mentioned, the bacteria are different, and taking pre and probiotics can help that bacteria go back to normal. There is a very nice study that shows that people that drink milk with probiotics have a much better control of their constipation than people that don't. So this can be a bit tricky and expensive. It's better to go and take milk or yogurt with probiotics than take the pills that we don't know exactly what they have inside. There is this yogurt that's called kefir that has a lot of pre and probiotics. It's not very delicious, but there are some now new ones that have mango or strawberries that you can associate. That simple intervention helps a lot because, again, it changes the environment of the microbiome in your belly and helps the bowel movements improve. The fourth is also something that I always feel guilty because I tell you to do it and I don't do it. That is exercise. Exercise helps a lot. It helps our bowels move well. So at least go for a walk, especially if you have some time after a meal and before going to sleep, because exercise will help the full metabolism get active and will improve the motility of your bowels. Let's say you hate vegetables and fruits and you will not eat any fiber from your diet. You can use fibers from over the counter like Metamucil, but this is something that you need to be very, very careful with because Metamucil is kind of like a sponge. You take your Metamucil, it goes to your bowels, and it's like a sponge full of fiber. If you don't drink a lot of water to hydrate it and make it soft, it will stay as a hard sponge in your bowels. So it's better to take your fiber from food, but if you completely hate it and you take Metamucil, make sure that you drink a lot of water with it. Senokot or Senna is also useful. Some people like it a lot, some people hate it. Usually it comes in the forms of pills or some tea, and it's better to take it at night so it works during the night, and then you have a bowel movement early in the morning. In terms of how many pills, we usually say between 1 and 4 every night. It's something very healthy, like doesn't have side effects unless you develop cramps when you take it. And it's something that can be useful before we jump into other medications. If we detect that you are not having bowel movements, we will prescribe something. And it's usually one of the powders like Restorolax or Laxidate that you buy over the counter, or things like lactulose. The most of the evidence in Parkinson's constipation is for Restorolax or Laxidate. This is called polyethylene glycol. And the recommended dose is a full 17-gram dose every day. And some people get very scared because before having Parkinson's, they heard that you shouldn't use laxatives every day, that is bad for you. Well, again, in Parkinson's, it's more dangerous to be constipated than to take laxatives every day. So if it's necessary for you to have a good bowel routine, it's safe to take laxatives in a regular basis. Sip of water. Let's jump into the bladder now. So again, bladder problems are extremely common in Parkinson's disease. If we go to numbers, we will see that it's approximately half of the patients. Again, I think that is much more common than that. We call the most common problem an overactive or hyperactive bladder. And the symptoms include that you need to rush to the toilet because otherwise you will not make it, that you have to pee many more times than usual, and the most common one, I would say, that during the night you have to pee many times. So why does it happen? Basically, the bladder has a big muscle around that contracts when you need to pee. The control of that muscle is in the brain. And the part of the brain that controls the bladder muscle is affected in Parkinson's. So instead of coordinating movements every time your bladder is full, you get contractions in your bladder at any time without any specific trigger. And that's why we call it hyperactive. There are some tips again in terms of what to do to avoid these symptoms. You can have a routine bathroom schedule. So for instance, every 2 hours, I go and try to pee, especially if I'm going somewhere else. I try to pee before I go out. Try to go at regular times. And this is something that you can chat with your care partners. Like, every few hours, can you remind me to go to the toilet? If you're going somewhere new, make sure you know where the toilet is so you don't feel in a rush if you have to go. If you have to travel, try to book your plane tickets close to the toilet so you don't have to run and you can see when the light is okay to go. Try not to drink a lot of liquids and caffeine after 6 p.m. It depends on your bedtime, of course, but try to drink a lot of water for constipation, but up to 6, and then don't drink so much because the bladder will continue to accumulate urine during the night otherwise. And if you're having issues with balance at night, and I know it's uncomfortable, and I know that nobody wants to do this, but it may be safe for you to wear some pads or have a urinal by the side of the bed instead of trying to walk in a rush in the middle of the night with the lights off and in the middle of the tree, because that's dangerous. That's where accident happens, and we don't want that to happen. There are some medications that help, and you need to tell your neurologist about it because family doctors sometimes are afraid of prescribing medications in Parkinson's. For many years, we only had these called anticholinergic medications that are pretty good for the bladder, but sometimes can produce hallucinations and cognitive issues, so we need to select for which patients those are appropriate. Sometimes your bladder misbehaving may be telling us that you need more Parkinson's meds, in fact, and optimizing your levodopa dose may help. And there's this medication that we use a lot more now that is called Mirabrigon, that has a different mechanism of action, helps the contractions of the bladder without giving you those side effects that the first category of medications can produce. So again, talk to your doctor about it, family doctor first, neurologist after, because it's something that we can easily treat and makes a huge difference. Because imagine that if you don't have to pee 3 times every night, you will sleep much better and you will feel much stronger in the morning. So that's something that needs to be treated. Some what we call red flags, or things that you need to be aware of. As I mentioned, the medications that you shouldn't take. Many times in men, hyperactive bladder symptoms are confused with prostate issues. I know many patients that had a TURP or like prostate surgery, and the problem was not that. In women, they may be told that it's prolapse or that it's a bit of pelvic floor weakness. So make sure that if you see your family doctor or urologist, you tell them, you know, I have Parkinson's and I heard that this can also be Parkinson's. If they say no, but there is clearly a prostate problem, of course, you should be treated. If there is a clear prolapse, you should be treated, but make sure they know that Parkinson's can also produce symptoms and that it has a specific treatment. Moving into sexual life changes, I know we have a very nice talk before about this. I cannot emphasize enough one problem that we have as physicians, and this has been well documented, doctors, mostly male doctors, are very embarrassed to ask about sexual life. So don't expect the doctor to ask, because we are terrible at that job. If you are having issues and you want to discuss this topic, I recommend bringing it to the table, because we know it happens, it's common, but for some reason, doctors don't ask about it. So usually, as mentioned, men can have initially more issues obtaining an erection. Women can completely lose sexual drive or having issues like reaching an orgasm. And it's also possible that the opposite may happen with some medications that we use, and you may have too much sexual drive. That sometimes it sounds like good, but it's not, because it may lead you to not be able to think about anything that is not sex, what is not good for functioning in real life. So they can be part of the disease process, but there are many other things that can be involved. As mentioned before, if you are anxious, if you are depressed, if you have diabetes, hypertension, overweight, for women, if you're going through a hormonal change, if you're going through menopause, anything can change sexual drive. So again, not everything is Parkinson's. Make sure you chat with your neurologist, but make sure that other things are well taken care of too. And in terms of tips for this, what can be done? Some people find that if they are more active physically, they exercise, brings the stamina up, and it helps with sexual relationships. As mentioned before, remember that sexual intercourse is not the only way to reach satisfactory intimacy. Communication is key, so talk about it. So you know, what is the best for this relationship? Are we going to try, or we don't want to try this, but we can try something else? The person that is by your side and loves you will understand, and you also need to be very aware of the other person's needs, of course. And if something that you think, okay, we really want to try, chat with us about it, because you know, sometimes like medications like Viagra, sildenafil help men with erectile dysfunction. Sometimes for women, we can prescribe hormonal medication or some lubricants or antidepressants or anti-anxiety medications. So if this is something that is affecting your quality of life, it's our role as physicians and healthcare providers to help you with it. So bring it, even if it's uncomfortable in the beginning, because we should help you with this. The next symptom, and I know this is a lot of symptoms, so I'm sorry if I'm going a bit fast, but I don't want to keep you here all Saturday. The next symptom that I'm going to chat about is what we call orthostatic hypotension. It's also an autonomic dysfunction symptom. So probably your doctor asks every time you see, have you ever felt dizzy or lightheaded every time you stand up, or when you stand up quickly? And unfortunately, this is a very common Parkinson's symptom, sometimes in the early beginning, sometimes as the disease progresses, sometimes related with some medications. And the symptoms can be lightheadedness or dizziness. Some people may experience headache instead. Some people have a very specific type of pain that is like like a close hanger pain in the shoulders that is also related with this type of low blood pressure. Some people may be confused, but makes sense because if you stand up and there's no enough blood going to your brain will not work very well. So some people get this postprandial confusion. They are in like having lunch, and after lunch they kind of stare a bit and are a bit confused. That's also likely to be low blood pressure. And if it's severe, it can lead to fainting and falling and breaking your hip. So it's not ideal. So again, drops in the blood pressure are part of the disease process. This happens again because of the autonomous nervous system. Neurons are affected and are not working properly. So every time I stand up, there is a reflex in my body that makes the blood pressure go up so the blood can reach my brain. In Parkinson's, that reflex is gone. So you stand up and your brain is waiting for that flow of blood, and instead of going up, it goes down. Then you feel dizzy and lightheaded. And some medications can make it worse, like even levodopa can make it worse. However, they are not the cause. The cause is still the Parkinson's. So some tips about this symptom that is pretty difficult and pretty annoying. Do not stand up too quickly. It's easy again to say, but difficult to do because you are not thinking how fast you're going to stand up every single time. You can elevate the back of your bed at night up to 45 degrees, so the changes in posture are not so big. Also, if you sleep in a very horizontal position, the blood will be distributed like all around your body, and when you stand up, it will drop faster. While if you sleep in a kind of semi-sitting position, that may not happen. Try to drink again a lot of water. Try to avoid having a large meal because that would make all your blood go to your bowels and it will predispose you to have drops in the blood pressure. You are free to put salt in your meals if you have this, and family doctors will freak out a bit about it because they are used to tell people to eat with low salt. But if you have orthostatic hypotension, you can eat chips and put as much salt as needed in your food, and that helps a lot because the salt will keep the water in your blood vessels. And sometimes people find that using compression stockings, the regular ones that you can buy in Shoppers or Amazon, help bring the blood pressure up. Be aware, however, that sometimes we do all these, and when we review the list of medications, we notice that because when you were 40, you had some high blood pressure, you are still taking medications for high blood pressure. So that if you are taking medications for high blood pressure, the first thing to do is to reduce the dose or stop them. So if you get to see us and we see that there is a medication like this, we may ask your family doctor to review the need. And it's very common for people that were hypertensive in the past to stop being hypertensive when they have Parkinson's, and moreover, get low blood pressure. So don't be afraid if you went from taking 3 pills for high blood pressure to taking none, or moreover, if we have to prescribe medications to bring the blood pressure up. That sometimes happens. Because again, having a good blood flow in your brain is very important for you to function. So sometimes we need to use these strategies. So usually we try this domperidone medication first to see if we can avoid the effects that levodopa may have on your blood pressure. But then there are other medications like fludrocortisone or midodrine that you can discuss with your doctor that are pretty helpful at keeping the blood pressure at a higher level. And we will start with a low dose and go slowly higher, because one potential risk if we bring your blood pressure too high is that you may lay down and have like 220/100 of blood pressure, and of course that's not desirable. So we do a very slow increase in the dose until we find the one that helps you. This is one that is very common, temperature regulation. And the reason is the same. So autonomic dysfunction leads to dysregulation in the control of temperature in the body. So some people will be very sensitive to heat, and some people will be very sensitive to cold, or both. So a common symptom is excessive sweating. And people tell, you know, I am not doing anything, but I'm sweating like if I was exercising. And sometimes that happens when you are off. That means when your medications are not working well, and we can adjust medications. Sometimes that happens when their medications are working, but you have a lot of dyskinesia, because dyskinesia by the end, if it's very profound, it's like being exercising. And sometimes it just happens when you are at rest, and it can be pretty annoying. It's hard to give you tips about it. It's a very difficult symptom to manage. Some general recommendations are to avoid hot or humid environments, avoid heavy physical activity in the heat, and wear some clothing that are suitable for the weather. Cotton clothes is usually better than some with a lot of polyester fiber. The other symptom that many of you may experience sometimes, particularly in Alberta, is cold hands and feet. And this is normal for everyone here, but particularly Parkinson's patients, because they lack of these reflexes that help us like warm up as soon as we get into a cold place, may feel the cold much deeper. So again, there's no particular treatment for this, unfortunately, but try to make sure you explain this to the people that live with you. So if you're putting the heating high, to like far too high, your care partner may say, okay, you're spending a lot of money and I'm really warm, so what should we do? And you can tell, like, well, you know, Dr. Bruno said I should put the heater up, because it happens. And you can also try to use clothes that are warmer, or use many thin layers of clothes instead of one big coat, because that also helps keep the heat within your body. Try to use like fleece or cotton or wool during the winter. Try to go to bed. Sometimes people go to bed with gloves and hats, and it sounds a bit strange, but helps a lot sleep, because it's horrible to sleep with your hands and feet cold. And then I went to, I have no conflicts of interest, but I recently went to Winners, and now that Christmas is coming, they have all these cute things that you put in the microwave for a few seconds and they warm up, and you can put in your hands or feet. They are also pretty useful to reduce the discomfort associated with the cold hands and cold feet. So this is a lot of information, I know, and I'm happy that I could share some of the tips with you, but I'm happy to answer. I want also to review all the questions that you may have, so I'm going to stop here. As a conclusion, Parkinson's is much more than motor. It's much more than tremor, stiffness, and slowness. And if you understand these symptoms, if you understand autonomic dysfunction, you can recognize what's happening to you, you will cope better, because you will be able to go to your doctor and says, you know, I had this, and I know that there is an alternative. So we'll help you. It will give you tools to deal with them. There are many alternatives to improve quality of life related with these symptoms. And the last conclusion to end is, like, we are so lucky to have this conference today. So thank you, Parkinson's Association of Alberta. And I hope you have a happy weekend.
Excellent. Thank you, Dr. Bruno. I've got a few questions that have kind of rolled in, and I think I see more popping up in the chat too here. Okay, so to start off, I've recently read that women often have different symptoms than men, and also may respond differently to meds and med changes than men. Of course, everyone's different and unique as well in their Parkinson's, but do you see differences in your practice, and does gender affect your recommendations for your patients?
Yes, 100%. Unfortunately, as you know, as it has happened with any other field in medicine, we neglected the differences in sex and gender for many years. Now we are understanding a lot more. And we are doing, in fact, here in our lab, we're working a lot on trying to understand women's health issues in Parkinson's. There's so many things that do not happen to men, like menstrual cycles, pregnancies, hormones, menopause. So how all those affect Parkinson's, or how Parkinson's affect all those changes, we have no idea. During the pandemic, for instance, it was very clear that the effects of the pandemic on women and men with Parkinson's were completely different. So yes, they are different. We don't know exactly to what extent. We know some of them, not all of them, but we're working hard to try to understand them a little bit more.
Excellent, thank you. I have another one here. It's my eyes water a lot. Is this something caused by Parkinson's or autonomic dysfunction? And is there anything I can do to help reduce this eye watering?
Yes, that's also a common one that has unfortunately no specific treatment. So it can go to both sides of the spectrum. Some people feel that the eyes are very dry, and some people feel that the eyes tear a lot. Part of the tearing a lot is related with the fact that you're not blinking as frequently. So if you're not blinking, you probably heard about the poker face and the lack of facial expression that some people with Parkinson's may have. If part of our blinking function is to get rid of those tears. So if we are not blinking as often, the tears accumulate and they come all together. So it may be saying that you need some more Parkinson's medication, even if it sounds a bit weird. Or if it's the opposite and it's mostly dry, it may benefit from some eye drops, like the regular ones, as the hydration ones.
Excellent, thank you. I have one here around constipation asking, does the use of magnesium or kind of magnesium vitamins help constipation?
I can say there's no evidence for it, but we know it does. So many patients use magnesium. So the goal is to find what helps you. So, you know, sometimes I have patients that drink a spoon of olive oil every morning, and that's enough. Of course, there's not going to be evidence for that. Nobody's going to run a study on that. It would be fun, but no. So it is to find what helps you have a good bowel movement that is easy to pass every day or every second day. But magnesium, I have patients that love magnesium, but there's no studies to support it.
That's fair. That's good to know. Can you explain the shoulder pain or the coat hanger pain? Kind of a little bit more, what is it like? They're asking if it's sharp, like a sharp pain, or more of like an ache.
No, it's mostly like a sharp pain in this distribution, and it's usually associated with dizziness. It's basically, we don't know exactly why it happens. It may be related with the blood flow going to the nerves that innervate that area of the body. But it's classical that patients feel this acute pain in this area, and then we check the blood pressure is very low, and if they lay down, the pain disappears.
Thank you. Got a couple more here. So what can I do to help manage the temperature fluctuations?
Yeah, I know. That's a very frustrating one. I don't think we have much to do about that. Sometimes just improving your Parkinson's treatment helps, because as I mentioned, some people have sweating or cold, particularly when the medications wear off. So if that's the case, that's pretty easy. We just rearrange medications accordingly. Sometimes, unfortunately, it's an independent factor and we have not much to do about it. So that's why it's important to know your body, because then you can prepare like your environment to it. But there's no pill. If you recognize, okay, every time my pills are wearing off, I'm sweating or I'm super cold, then that's a very good clue for us. And okay, we will reduce the wearing off. But if it's something that happens random, independently of the time of your pills, unfortunately, there's not much that we can offer.
Thank you. I have two surrounding foot pain. So one's, what about the tingly burning sensation in the feet? And the other one's about foot cramping. Kind of what can help both of these foot pain symptoms?
So this is different, no? So these are two different issues, or three, because I see there's also a question about restless legs. So there's so many things that can happen in your feet in Parkinson's. So if your feet are feeling all the time tingly and numb, that's unlikely to be the Parkinson's. So if it's numb and tingly, that speaks mostly about the nerve problem, and we may need to do a nerve conduction study, make sure your vitamin B12 levels are good, make sure you don't have diabetes or any other problem affecting your nerves. Because nerves in the feet are usually not affected by Parkinson's. What are usually affected in Parkinson's are muscles, and it's something that we call foot dystonia. These cramps in the back of your leg, or your toes curling, or your big toe going up. That is very painful. It usually tells us that there is not enough dopamine in the system. And sometimes medications can help, but other times we just finish a study to show that injecting botulinum toxin in the muscles that contract helps get rid of that cramp. So that's something that you should also discuss with your doctor if it's happening very often. Some people like wake up in the middle of the night with a cramp. The third thing that can happen with feet at night in Parkinson's is restless legs. That is a different thing. It's the diagnosis itself, with or without Parkinson's, but it's more common in people with Parkinson's. We think they are related because it responds to the same medications. But restless legs is defined as an uncomfortable feeling. It's not tingling, it's not numbness, it's not pain, and it's not cramping. It's like as soon as you get into bed and your feet touch the bed sheets, you feel the need to move them. And that has specific treatments, and your family doctor should check your iron levels. They are related, but it could be also independent of Parkinson's.
Excellent, thank you. I've got two more questions here. So one is, the most cough and cold flu medications say they're not suitable for people with Parkinson's. Do you know what the active ingredient that is not suitable for people with Parkinson's is in there? And do you have any recommendations of cough medicine that is okay?
Yeah, so I think some of the cough medications, I'm not 100% sure, I want to be honest about this, may have a little bit of opioid derivatives, and that can make some things worse. I don't know exactly which ones are completely contraindicated. Probably it's not a very hard contraindication. But also remember that we don't really know if cold flu medications work in general. So it's better to chat with your family doctor and wait, and if it's a flu or if it's a viral infection, take some acetaminophen, some Tylenol, or some ibuprofen. Wait until the symptoms resolve. We don't, in general, for instance, some of the cold medications are kind of dangerous because they can produce like constriction of the vessels in your brain and can lead to little strokes or TIAs. So these are not medications that we recommend in general. I would try to avoid them. Someone has a runny nose. Sorry, I want to mention.
Yeah, that's the last one I've got is, what about runny nose every time I eat?
It's interesting. I have no idea about that. I never heard that, but if it's something common, we should explore it. So it's something that is I never heard about before, but I will do some research, I promise.
Excellent. And then I've got one last one. I find I get really tired or dizzy after eating. Is this Parkinson's related?
Could be, yes. It could be this low blood pressure problem, and sometimes it's dramatic. Sometimes it's I have a meal and I black out. But sometimes it's this, I have a meal and I cannot function for a few hours. And it's not really sleepiness. It's not that, it's just your body doesn't respond. And again, it's because you have a meal, you are all like busy with digestion, and you don't have enough high blood pressure to reach your brain and to make you function properly. That's why like small snacks throughout the day with a lot of salt sometimes are better for this, for people that have these symptoms.